Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a randomized, double-blind, placebo-controlled phase 2 study of AMG-386 combined with weekly paclitaxel in patients with recurrent ovarian cancer by Beth Carlan et al. My name is Panagiotis Konstantinopoulos, and I am an attending oncologist at the Beth Israel Deaconess Medical Center and an assistant professor of medicine at Harvard Medical School, Boston, Massachusetts. My oncologic specialty is gynecologic medical oncology. Inhibition of the VEGF signaling pathway using agents such as bevacizumab, which binds to VEGF itself, or tyrosine kinase inhibitors such as etiranib, which directly inhibits the VEGF receptor, has received a great deal of attention by investigators studying ovarian cancer. Of these drugs, bevacizumab is in the most advanced phase of clinical evaluation and has been associated with a 16 to 21% response rate in recurrent platinum-resistant disease as a single agent. Furthermore, in the first-line setting, 2 phase 3 studies, GOG-218 and ICON-7, have shown that concurrent plus maintenance bevacizumab, combined with standard platinum and taxane chemotherapy, prolongs progression-free survival compared to placebo. The side effect profile of bevacizumab, which is generally shared by inhibitors of the VEGF signaling pathway, includes hypertension, proteinuria, thrombotic or hemorrhagic events, and the possibility of gastrointestinal perforation, which was as high as 11% in the phase 2 study by Canister et al. Involving heavily pretreated patients with platinum-resistant relapse. Although VEGF inhibitors have activity in ovarian cancer, resistance frequently develops and is thought to be related to the presence of multiple redundant angiogenic pathways, which may be recruited by tumors to overcome VEGF inhibition. For this reason, targeting non-VEGF related angiogenic pathways may be an attractive strategy to overcome resistance to VEGF blockade. Furthermore, it is conceivable that combining drugs that target different angiogenic pathways with non-overlapping toxicities may translate into a more clinically meaningful responses than VEGF inhibitors alone. In this issue of JCO, Carlan and colleagues present data on a non-VEGF-related antiangiogenic approach in ovarian cancer, namely targeting the Angiopoietin-Tie2 axis using AMG-386, a novel angiopoietin antagonist peptide Fc fusion peptibody that selectively binds angiopoietin 1 and 2 and prevents their interaction with their receptor Tie2. The angiopoietin-Tie system consists of 2 tyrosine kinase receptors, Tie1 and Tie2, and 3 secreted ligands, angiopoietin 1, 2, and 4. Angiopoietin 1 functions as a Tie2 receptor agonist, while angiopoietin 2 normally functions as an angiopoietin 1 antagonist. Angiopoietin 1 promotes survival of endothelial cells and maintains the endothelial barrier and the integrity of existing vessels. Conversely, angiopoietin 2, functioning as an angiopoietin 1 antagonist, increases vascular permeability, destabilizes quiescent vasculature, and primes the endothelial bed for angiogenesis. While angiopoietin 1 is constitutively expressed in more adult tissues, angiopoietin 2 is primarily expressed in tissues undergoing vascular remodeling and angiogenesis. In cancer, overexpression of angiopoietin 2 and increased angiopoietin 2 blood levels relatively to angiopoietin 1 levels have been reported, and correlate with poor prognosis in various tumor types, including AML, CLL, breast, and colon cancer. In ovarian cancer, angiopoietin-1 expression is reportedly lower than in normal ovary. The angiopoietin-2 to angiopoietin-1 ratio is shifted in favor of angiopoietin-2 and thus in favor of angiogenesis. In addition, a high angiopoietin-2 to angiopoietin-1 ratio has been associated with inferior outcome in this disease. The rationale behind using AMG 386, which inhibits both angiopoietin-1 and 2, is that while selective inhibition of angiopoietin-2 leads to reduction of the number of tumor blood vessels, unopposed angiopoietin-1 promotes normalization of the function of the remaining tumor vessels. Conversely, simultaneous inhibition of both angiopoietin-1 and 2 by AMG 386 prevents normalization of tumor vessel function, leading to reduction of both vessel number and vessel function, and thus greater tumor death. This was shown in tumor xenograft models whereby combined angiopoietin-1 and 2 inhibition led to greater tumor suppression than selective inhibition of either angiopoietin-1 or 2 alone. In the present study, 161 patients with recurrent ovarian cancer and up to 3 previous anti-cancer therapies were randomized 1-to-1-to-1 to receive paclitaxel 80 milligrams per meter square once weekly, 3 weeks on, 1 week off, plus intravenous AMG 386, 10 milligrams per kilogram every week in arm A, or the same chemotherapy with AMG 386, 3 milligrams per kilogram every week in arm B, or the same chemotherapy with placebo in arm C. The primary endpoint of the study was a pure VEGF inhibitor therapy, and 47% of patients were platinum-resistant or refractory. The median progression-free survival in the 2 AMG 386 arms A and B was 7.2 and 5.7 months respectively, compared with 4.6 months in the placebo arm, but the difference was not statistically significant. The overall survival data were not mature at the time of this analysis. The hazard ratio for progression for the 2 AMG 386 arms combined was 0.76, which was not statistically significant with a p-value of 0.165. A pre-specified exploratory analysis suggested a statistically significant dose-response effect for AMG 386 on progression-free survival with a p-value of 0.037. The toxicity profile of AMG 386 was manageable and distinct from that of VEGF pathway inhibitors. The incidence of grade 3 or more adverse events was similar in all arms, and the most frequent adverse events were peripheral edema, fatigue, nausea, and alopecia. 2 AEs emerged as likely being associated with AMG 386 treatment, peripheral edema and hypokalemia. Unlike VEGF inhibitors, no patients experienced grade 3 or more hypertension, proteinuria, or impaired wound healing. And the incidence of hemorrhagic events and arterial and venous thromboembolic events was similar across the 3 arms. Importantly, there were no bowel perforations in either of the AMG 386 treatment arms. An important limitation of this study was the relatively small number of patients enrolled, which was consistent with its design as an estimation study. The observations that weekly AMG 386 plus paclitaxel may prolong progression-free survival compared to paclitaxel alone needs to be confirmed in a larger study, and this is currently being investigated in the Phase 3 TriNova-1 study. Although targeting the Angiopoietin-Tie2 axis may be a promising non-VEGF-related antiangiogenic strategy in ovarian cancer, several questions remain to be addressed. First, given the dose-response effect suggested in this study, would AMG 386 doses higher than the 10 mg per kilogram weekly provide greater benefit? In a Phase 1 study of AMG 386, doses up to 30 mg per kilogram were well tolerated without reaching the maximum tolerated dose. Second, what is the efficacy of AMG 386 as single agent in ovarian cancer, and how does this compare to the activity of VEGF inhibitors? Third, does addition of AMG 386 to other chemotherapy agents improve their efficacy? An open-label phase 1b study of AMG 386 in combination with either pegylated liposomal doxorubicin or topotecan is currently recruiting patients, and an interim analysis presented at the ASCO 2010 annual meeting reported that both combinations are tolerable. Furthermore, given that blood vessel normalization by angiopoietin-1 may augment cytotoxic drug delivery, would selective angiopoietin-2 inhibition be more preferable to inhibition of both angiopoietin-1 and 2 when combined with conventional cytotoxic chemotherapy? Fourth, does addition of AMG 386 to VEGF pathway inhibitors improve their efficacy? This may be an exciting strategy given the non-overlapping toxicities and the potential for non-cross resistance by simultaneous inhibition of distinct angiogenic pathways. Phase 1 studies of combinations of AMG 386 with bevacizumab or sunitinib or sorafenib have shown that they are tolerable and that the PK profiles of neither AMG 386 nor the VEGF inhibitors were markedly affected. Design of future clinical trials will hopefully delineate the role of this exciting anti-angiogenic strategy in ovarian cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.